Yep, okay, great. I just want to start with a quote by Greg Bortowitz, who's a US artist, writer and AIDS activist. And he wrote, there is no better hero of a story than the writer himself, and there's no better authority on a disease than the diseased. And he wrote those words in 2000. I think they're really instructive for those of us who explore, investigate, analyse, and create spaces and places for health and well-being. They remind us of the dynamic behind many of the practice we engage in, from co-design to social practice to participatory design, experience-based design, and socially engaged art. Obviously, all of these practices in some way are about people, although we have learnt in previous presentations they're also about ecosystems and the way that people operate in systems and processes. But essentially, in terms of the practices that I've discussed, they're about person-centred or patient-centred care in the context of health and well-being. So the assertion here, and in terms of Bortowitz's words, is that people working with practices such as these are assuming, if you like, a democracy in action, or at the very least, consent, engagement and participations in the settings that they work. So back to Greg Bortowitz and his words around the authenticity of one's position and experience. So as we have heard, there's no better place to commence than about the hero of the story. So I'm also going to introduce my story to a degree and of my experiences with disease and in health. So this will set the basis of many of the research projects that I've worked on, which I'm going to discuss today, which traverse across creative arts, design and health. So let's start. I've been dying to see what this looks like up large. That's me with lots of stitches in my face. And in fact, when I wrote the abstract, I wrote the abstract looking like that, and I clearly wasn't feeling very happy with myself. I'd had surgery on my face to remove a basal cell carcinoma, which was at the top of my nose, and had been progressively getting larger over time and actually quite painful in the weeks leading up to its removal. But in the 1990s, I had a malignant melanoma removed from here, from my chest. And that actually was a malignant cancer. And it was removed at Guy's Hospital in London. So there's other experiences in my health history. In fact, for this presentation, I actually looked at my bio and then actually tried to transfer it into a medical history, which I was going to read out, but maybe I'm not so sure now. But just to suggest that I think that what we really need to also to be thinking about is our position as people, as humans ourselves, in patient-centred design or people-orientated practices, from participatory design to socially engaged art. So I've worked with design, but I more predominantly work with the arts. I work in a school which is a basis in terms of fine art and photography, but I actually work across many different practices. And I'm going to show you a series of 3 projects that I've worked on since 2008, which have been around about art interventions and applications for healthcare settings. So this comes out of a history of my own, which has informed a lot of these projects. As I've mentioned, I've obviously had issues in terms of skin cancer. And this led to my interest in the way that art actually intervened and responded to issues around public health. So first of all, I was interested particularly in artistic and activist responses in terms of cancer and HIV/AIDS. And that was very much to do with the time that I was diagnosed with the melanoma, which was in the 90s, and I was living in London. But then, many years after working on projects which probe the cultural construction of disease, ill health, public health, I then actually started getting more interested in working with applications and interventions in healthcare settings. So the first project that I want to discuss is Designing Sound for Health and Wellbeing, which has a title very similar to this fantastic network that Sarah and Shanti and Lorraine have set up, which I thank them for. But I had quite a long history working with St Vincent's Hospital. First of all, I commenced working with them in 1998 when I curated an exhibition called Viruses and Mutations for the Melbourne Festival. And then in the 2000s when I worked with the department, working with my undergraduate students in the School of Art and working on projects for the hospital across campuses. The hospital has a campus or setting in Fitzroy, but also in other parts of Melbourne. So for this project, Designing Sound for Health and Wellbeing, it was an interdisciplinary project. There were colleagues from the School of Art that I worked with on the project whose areas crossed sound and music, art history. And in terms of our partner, St Vincent's Hospital, we worked with emergency medicine and psychology researchers and practitioners. So just to let you know just a little bit about St Vincent's Hospital in terms of the emergency department, it's an adult tertiary referral department, and at the stage that we did this project, it saw around 40,000 patients a year. And our project was a 3-stage interdisciplinary project. For this project, we received ethics approval from the hospital and we registered it as a clinical trial. So many of the projects that we've already seen didn't actually sort of eventuate from what I could tell in terms of clinical practices, but we actually did in terms of this project. So our interest was in investigating whether music and sound can alleviate stress and anxiety of patients as they wait for care in an emergency department. And this was because there's a lot of literature about the application of music in medical settings, but not so much about how they're received by patients, and particularly also in terms of how they function within an emergency department setting. So, and even rarer, well, we couldn't actually locate it, were projects, and it might have happened since we've actually worked on this research, where people have actually composed compositions especially for patients in a medical setting, and in this case it was the emergency department. So here you've got the ubiquitous hospital corridor, but in this instance it's in terms of the emergency department at St Vincent's Hospital. So just in terms of stays in emergency departments, most of you, I'm assuming that many of you, if not most of you, have had some interaction with an emergency department at some point. So there is stress and anxiety for everyone who goes to that department within a hospital. You're either going as a patient or as a friend or as a carer or a family member, and it's deeply stressful. You don't know how things are actually going to go. And so the first instance, and we actually had a look at some interesting waiting rooms before, is that you often end up having to wait for a long time in very uncomfortable waiting rooms. And interestingly, it is the people that leave emergency departments earlier than in terms of when they should actually be seen that are most likely to end up in quite serious conditions and die. So it's really crucial that departments such as emergency departments are comfortable and welcoming and relax people. Okay. So for our project, it was a 3-phase project. We composed, in the first instance, 20 sound compositions, 10 electroacoustic compositions, and 10 soundscapes, which are of environmental recordings or environmental sounds. So there were 20 compositions of a minute each that were tested on emergency department patients. So for this phase of the project, we had 100 patients enrolled, and they were adult patients. And the exclusion of this part of the trial was that we weren't including people in in this phase of the study who couldn't speak English, who had cognitive impairment, or were highly dependent on care or unable to consent. And that was actually our exclusion preferences for the other phase of the trial as well. So the patients listened to our compositions on iPods, which when I was sort of like thinking about this, is just interesting in terms of sort of like technology is superseded very quickly. And what they did was indicate on a questionnaire the preferred sounds. And so what we found that the preferred sounds of quite a vast array of percussion, instrumental, and sounds of urban and rural environments, the preferences were for percussion and guitar, and water, bird and frog sounds. So these sounds were then adapted and developed into longer compositions. Which were tested in the third and last phase of the project. So they're developed from 1-minute compositions into 20-minute compositions, and we also recorded the ambient sounds of emergency department as well, which was going to act as our placebo in our clinical trial. So for our clinical trial, which was a randomised double-blind control trial, we included patients that were triaged as Category 3 patients, and that was basically that they wait at least 30 minutes if they're waiting for that long. So the inclusion and exclusion criteria was the same as what I mentioned for the earlier part of the trial. And for those who are medical researchers or psychologists, the primary endpoint of the self-reported anxiety was Spielberger State Trait Anxiety Inventory. Don't ask me about that, I'm not a psychologist, but I just wanted to mention it to those medical researchers here who will know what I'm talking about. So we enrolled 175 people into the trial, but 170 people completed it. So they were divided into 5 groups who listened to 4 20-minute compositions, an electroacoustic composition, a soundscape, which was basically a journey, a 24-hour journey through a rural environment. So obviously that was informed by the frog call, the bird call, frog call. I don't know if frog call is actually a term, but anyhow, it will do. So the results were very interesting. In fact, we didn't actually realise that we were going to do as well as we did with this trial. We're all quite amazed. The 4th intervention was a composition which was basically the sounds of the emergency department, which was a placebo, as I talked about before. And the 5th intervention was basically nothing. Those people in that group didn't have headphones, weren't listening to one of the compositions, but still had to fill in the questionnaire about about matters to do with stress and anxiety. So in terms of the trial, 170 people completed it. 54% were men, and there was a median age of 52, and the age range of this group was 35 to 69-year-olds. 69% needed pain relief during the actual their time listening to the compositions, but there were no differences between the groups in age, gender, or pain relief required. So, as I sort of hinted, the results were quite extraordinary. So the mean normal state anxiety scores, if in terms of what I was talking about before, is, I don't have this data up on the screen, but it's something like 35.7 for men and 35.2 to women. So that's the sort of normal anxiety scores in terms of this inventory. I'm actually going a bit slow. I've just seen Shanti, thank you. Was quite different to the results that we got, which was that after the testing, the scores were that our post-test group indicated no or low anxiety because of the compositions, but there was no changes in the control group. So it was really quite interesting in terms of the effect of the sound compositions on the people in this trial. So they went from pre-test in terms of moderate anxiety to no or low anxiety. So what's really sort of interesting in terms of this project is that it tells us that there is room for sound art and music and art, and of course design, in terms of clinical interventions within hospitals. So we can actually use design and art in clinical practices as well. And the data here and for this project tells us that sound and music can alleviate stress and anxiety in patients. But we found what was interesting was that really this in testing sound compositions on patients this way was a singular experience, but the actual whole environment of the hospital department was important in terms of the sonic experience, and that should actually be taken in terms of, for designers and architects, there's real need to actually look at the calming and the potential less frenetic, less erratic sonic environment of these sorts of departments. I just want to move on to another project that I worked on called Emergency Jewellery. And this project actually commenced when I had tests in a hospital for quite a minor condition and was questioned about some medical allergies I had to some medicines by the doctor who was treating me. And the doctor told me about SOS jewellery, which is jewellery that you can get as sort of like pre-ordered through the internet, it's mass manufactured. And if you have allergies or to pharmaceuticals, or you've got diabetes or some medical condition that you need to actually let people know about in times of crisis, paramedics or medical practitioners, you wear or you have like a little card in your wallet giving that information. So I decided to approach Leo Heiss, who's a designer here in the School of Architecture and Design, although the title's obviously going to change from next year. And then we worked with Paul Beckett, an electronic engineer, to design some SOS jewellery with myself as the case study. So you can see here, you can just slightly read it, a test piece for this project, which notes the allergies that I have to medication. And this slide shows the final pieces, which are at the back of this cabinet. The pieces at the front are jewellery pieces designed by Leah, which are pieces designed to inject insulin into diabetics, and the pieces at the back are the SOS jewellery designed with me as the case study. So this is another project in terms of sort of like where my health experience has actually informed a design project as an application. The next project I just quickly wanted to talk to you about is a project that's just commenced. It commenced in October this year, and I'm working with a team, interdisciplinary team of researchers based in Stockholm. So it includes medical and nursing researchers from the Karolinska Institute, a choreographer from University of Stockholm, an aged care researcher from Stockholm University, designer from Konstfack, which is an art design and craft university, and a co-design researcher from King's College London. I'm leading a project in this project, which is basically the project's brief is to investigate space and place in aged care and end-of-life care settings. And as part of a larger project called Du Bra, which translates roughly to a good death in Swedish, in my very bad Swedish. And so there's Du Bra is a program of projects. One side of the program is working on projects about end-of-life care settings, but in terms of public health, inroads into public health policy. And the other side of the program has projects around space and place. So there's a trolley for the people who like trolleys, because we've talked about trolleys before. But this is a day room in a ward in an aged care setting in facility in Stockholm, in central Stockholm, called Serafen, that we're working on over the next 3 years. And we're investigating space and place in this setting through interviews and discussions with staff and residents, but also we're using choreography as our method to understand space and place. So choreography, if you like, is the organisation of people in terms of their movement through organisations, through space, through place. So we're taking quite a different approach to this as a team with members of the team who aren't choreographers. Although, as you can see, the projects I've worked on are across mediums and across disciplines. So for this project, I keep joking to the choreographer that I'm a choreographer now, but I'm taking it seriously. I'm going to be a choreographer for this project. So our interest is in understanding the way people move, the way their bodies interact, the way we hear sound in terms of movement within this space and place, the way that people interpret, feel, are intuitive, are anxious about the space and place, and through a study and observation of their movements. And because in the essence what we're actually working on is a social choreography. And the outcomes, this has only just started, so it's very early days, but what we're intending to do is obviously write and present about outcomes of this project, which we're working on with Stockholm Elder Care Bureau. But we're also wanting to use the choreography to inform a performance-based outcome as well. So just to conclude, just to go back to my medical backstory and personal lived experience, this is a photo of my dad, taken a few years ago when he was in an aged care facility, and this is really unethical because he'd hate me showing this photograph. He didn't really like being in this place. But I'm just wanting to sort of get back to this to remind us all, as I keep reminding myself, is that our own lived-in experiences can't be divorced from what we're actually doing in these projects and in these healthcare settings, where people who actually use them, our loved ones, use these settings. So I think it's really important to get back to our own lived experience when we're thinking about and working on these projects, so that it's not just about making projects for other people, it's also about making projects for our own well-being. Thank you.